Okay, we'll discuss after the talk.
So
It has come to. Sorry about this slight delay. Start the time and we can start.
Should we start over or start from here?
Yeah, I can start, whatever you feel like.
Okay, so I'm going to talk about neurodevelopment after anti-VEGF treatment, and VEGF is suppressed after anti-VEGF. Systemic VEGF is suppressed after anti-VEGF treatment in the eye in neonates. And so the question is this meaningful? We don't know what the optimal level of VEGF is in a neonate. We don't know the systemic level or the intravitreal level that's normal. We don't know if VEGF is elevated normally in a preterm neonate, and thus if a decrease in VEGF after anti-VEGF treatment has any meaning. Interestingly, in the Rainbow study, they found a decrease in systemic VEGF after laser treatment, which may be related to oxygen during the procedure, but we don't really know why that happened. So neurodevelopment and ROP are intertwined. So in the cryo-ROP, the threshold ROP was associated with higher rates of developmental, educational, and social challenges. Other studies have shown that severe ROP is correlated with lower IQ, and that higher levels of neurodevelopmental delay occur with zone 1 ROP and less with zone 3 ROP. Other studies have shown correlation between visual development, not necessarily ROP, but visual development and neurodevelopment. So impaired fixation decreases the ability to walk, and patients who had impaired fixation were much more likely to have mental developmental delay as well. So predictors of neurodevelopmental delay is ROP, bronchopulmonary dysplasia, and interventricular hemorrhage. But since ROP is a predictor of neurodevelopmental delay, there's a lot of factors that it's hard to tease out if your treatment for ROP caused a neurodevelopmental delay or it would have happened anyway. So what I'm going to discuss now is some of the outcomes we found at the University of Chicago and compare these to other studies and discuss future possible studies. So before BROP, we treated most patients with laser. After BROP, we started treating mostly with anti-VEGF. So we have a before and after study, which it's not randomized perspective, but it's a little bit less biased than many studies where the sicker infants or babies with worse ROP were treated with anti-VEGF, but the healthier ones with less severe disease were treated with laser. So ours is a before and after treatment. We looked at markers for severe neurodevelopmental impairment, and so that's death, cerebral palsy, bilateral visual impairment, and hearing loss. And then we also, as a secondary outcome, looked at Bayley 3 measures. Our baseline data are basically the same for laser and Avastin-treated patients, although there was a difference in male gender. There was no difference in the primary outcomes between laser and bevacizumab treatment, no difference in death, cerebral palsy rates, hearing loss, although there was a trend towards more bilateral visual loss in the laser group, and then if you controlled for zone of ROP and hydrocephalus, actually there was significantly worse, significantly more bilateral visual loss in the laser group than the bevacizumab group. In terms of predictors for cerebral palsy in these babies, the strongest was hydrocephalus. And these were all adjusted for zone of ROP. If we looked at ocular visual outcomes for predicting cerebral palsy, bilateral visual impairment was the highest predictive, and bevacizumab treatment, zone of ROP or APRP were not predicted, but bilateral visual loss was. Now the secondary outcomes are Bayley 3 measures. These were not different between the laser and bevacizumab groups either. And then if you look at different measures of the Bayley 3 scores, these again were not different between the laser and bevacizumab groups. So the results of our study showed that bilateral visual impairment was more common with laser than with anti-VEGF. Bilateral visual impairment was highly correlated with cerebral palsy. There was no statistical significant differences in rates of hearing loss, death, or cerebral palsy by treatment group, and there was no obvious differences in the Bayley scores, although we had less patients who actually came to Bayley score testing. So this is consistent with other studies around the world. Most other studies have failed to find a difference in neurodevelopmental outcomes between anti-VEGF and laser. The one study that some of you may be familiar with was Morin et al. Published a few years ago in Pediatrics, and they purported to show a difference. But I'd like to point out a few flaws in their study. If you look at the bevacizumab group versus the laser group, there's significantly sicker infants in the bevacizumab treated group, as seen in the SNAP-2 score, which is the first yellow line there. And the ROP was much worse in the bevacizumab group than the laser group. And both of those so you have sicker infants and infants with worse ROP, and you would expect those infants to have worse neurodevelopmental outcomes. So their study has bias, and they also had a strange exclusion criteria where 10 patients were excluded for inability to perform the testing. 9 were excluded in the laser group and only 1 in the anti-VEGF group. And these included severe developmental delay, blindness, deafness, uncooperative behavior. And all of those should have really been categorized as unfavorable outcomes rather than excluded from analysis. And if you redo their analysis, including these as negative outcomes, then the difference between the two groups disappears. It's also difficult to perform Bayley evaluation in children with visual difficulty. The Bayley test, for some of you who may not know, is a long test, and it's usually performed at age 2 or so, and there's vocabulary where you have to identify objects in pictures. That's a visual task. There's grasping objects to demonstrate fine motor skills. If you can't see it, it's going to be hard to grasp. Dynamic movements, test gross motor skills. Again, motor planning can be delayed if you can't see. And then social engagement, if you're unable to see other facial clues, this is hard to measure in someone who can't see. So it's really, there's difficulties in the neurodevelopmental testing in children who are blind. You have to put a spoon in a cup, build a tower of 6 cubes, looks at toys, name objects. So really, this test may not be valid for infants or toddlers with visual difficulties. And so we have multiple small retrospective studies. ROP is a predictor of adverse developmental outcomes. A lot of these kids also have bronchopulmonary dysplasia and interventricular hemorrhage, which is a confounding factor. And this testing is usually performed at 2 years. So you have a lot of difficulty in actually finding the data. Is there neurodevelopmental delay in any of these patients? And one solution to this is called the general motor assessment, which can be done about 3 months post-term, and they measure fidgety movement. So more normal infants should have fidgety movements. If there's lack of movement, that's abnormal. And so there's an app on a phone that you can record the baby for a minute while it's lying on its back, send to a reading center where they can, in a mass fashion, grade whether the baby has fidgety movements or not. And that has been shown to correlate with rates of cerebral palsy and neurodevelopmental delay. And the general motor assessment is actually more sensitive and specific for predicting cerebral palsy than cranial ultrasound, MRI, or neurologic examination. We've been performing this at the University of Chicago for the past few years, and in the interest of time, I'll move forward. But basically, it's demonstrated that it can predict who will at 2 years have cerebral palsy, and this is done at 3 months post-term. So it's a relatively low-cost tool. It's more accurate than neuroimaging. It's a biomarker that can be used in clinical trials. Given that finding the difference between laser and in neurodevelopmental outcomes in laser or bevacizumab treated infants, probably you need excess of 500 patients to exclude a 10% difference. This is something that potentially could be done to answer these questions. So in summary, no convincing study has shown neurodevelopmental effect of anti-VEGF treatment. There's bias that exists in treating sicker infants with anti-VEGF. Neurodevelopment and ROP and vision are intricately related. Bayley 3 scores rely on visual input, so there's bias, so there's confounding factors there. And the general motor assessment may be a good way to move it forward. Thank you.
Thank you very much. We'll have all the questions in the end once you finish that. Thank you. Thank you, Michael. Who is the first three speakers around here? Sharifuddin Ahmed? No? No. Okay. No, Dr. Noela Prasad, not here? Okay, I think Dr. Jayabhaskar, you can start. Allied Ophthalmic Personal Training Accreditation, a case study from Singapore.
Good afternoon, everyone.
See the next speakers around.
Good afternoon, everyone. I would like to thank the organizers for inviting me to speak about our allied health training development. And I will share our case study. Basically, I will talk about the increasing eye care burden and the manpower shortage that is we are experiencing both in developed and developed countries, and how a training program for AOPs will help, and how our accreditation process will enhance the quality of the education. And I will share what we have done to address these issues. So all of us know this major study which has talked about the eye disease burden, and the 1.1 billion number is quite scary. But if you look at the other number, which is 89% of the visually impaired people living in the low and middle income countries, which is the major one. And when you take into this consideration of the manpower, when you look at the ophthalmologists, optometrists, and the allied health and the community eye care workers, which is the major crux of the manpower which is required to address this major eye care disease burden in the rural and semi-urban settings, we don't have that much of allied ophthalmic personnel. The allied ophthalmic personnel in Indian context and other places as well in the past used to be called as mid-level ophthalmic personnel. So WHO has actually kind of recommended to use a standardized nomenclature of allied ophthalmic personnel, which is what I'm going to use in the presentation. So I call them as silent warriors in the war against the blindness. A majority of them are the key personnel working in the eye camp screening and other aspects of the visual treatment in the eye care process. And I had an opportunity to attend the Netra Kumbh, which is happening in the Kumbh Mela. So it was really an eye-opening experience for me to look at the ophthalmic assistant trained in those eye hospital involved in the Netra Kumbh. We were able to screen about 1 lakh patients in a few weeks, and then distributed 80,000 spectacles, which is an amazing feat. So that kind of impactful activity can happen if you have trained AOPs in place. And also in 2017, there was a global forum for healthcare manpower met in Dublin, and they called for addressing this shortage of healthcare workers. And this is the right time, actually. The people involved in training AOPs should join together and galvanize to form a global training program that can benefit everyone. So there is a diversity of training programs available in different parts of the world based on the curricula, based on the training duration, and also most of the training are on-the-job training, and there is lack of validation in terms of the assessments and continuity of learning, the continuous professional education part of these educations. And also they need to have a proper recognition of this workforce, as well as proper career path development as well. So that is where the accreditation comes in. Accreditation is a process designed to ensure the training programs are of higher standard and have higher quality in terms of delivering training outcomes. So it actually assesses the training program based on standardized guidelines. The standardized guidelines are a certain set of protocols which helps you to assess the training program, whether they are able to deliver proper pedagogy and andragogy, so that the quality of education provided is measurable and also able to deliver better training outcomes. So there are entities like JCAHPO, Joint Commission of Allied Health Personnel in US, that is an organization which works on developing the standardized guidelines and curricula. So we actually adopted their curricula and developed our training program. So those kind of standardized guidelines will help the institutions to develop structured training programs. And we can use standardized rubrics to assess the competencies as well. And the benefits of accreditation is to give the recognitions to the students who can actually pass through the training program, and we are able to convince that they are competent and ready to practice at a certain level. And also it provides opportunities for the training programs as well as the program directors to assess and reflect from the feedback from the international accreditation process so that they can refine and improve their program. The continuous improvement of the programs in terms of quality improvement also happens through this international accreditation, and also it helps in defining the career path for the allied healthcare personnel. So with that, I'll just move to the case study. As you know, Singapore is a small country, which we have about 5.5 million population, and we have quite a significant number of eye care burden as well. And one of the things is myopia is a major one, and diabetic retinopathy and other major common eye diseases. So what we did was, as a training institution, we looked at the increasing patient load and looked at what is our manpower gaps, and we identified some of the capacity development aspects, and we realized that we lack, I'm talking about in 2013, 2012, we didn't have a competency-based training program at that time. It was mostly on-the-job training, and we didn't have an accredited training program for the AOP staff. What we did was we also did a system dynamics modeling to assess the workload or the type of work that is required in another 25 years, which is up to 2040. This was done in 2015. So we actually looked at each and every aspect of the eye care personnel for kind of providing the services for common eye diseases. And we assess the disease prevalence for next 25 years and how the workload is going to change in terms of if we carry on doing the same business, how it is going to be, and if it is a new business, new model of healthcare where optometrists and nurses can provide primary eye care kind of a model, and also if we have combined mixed model of care, and what kind of manpower that is required for next 5 to 25 years kind of a time frame. So what are the number of people like ophthalmologists, optometrists, ophthalmic nurses, ophthalmic technicians, and all those different categories. So this actually gave us a clear indication of there is going to be a significant increase that we need to address in terms of developing this workforce. So just to give you a background in terms of where the education was in the past, it used to be 100-hour didactic lectures for all those who join our institution, and they go through this training program, which is also combined with the on-the-job training for this workforce. And nurses had advanced certificate program for the ophthalmic nursing, which we stopped in 2012. So there was no educational program per se in a standardized way. So we wanted to move in terms of ophthalmologist-led eye care team, where different workforce kind of works together to deliver a team-based eye care. So we developed a comprehensive eye care training model which can transcend across the entire pyramid of eye care workers, eye care personnel who are working in the community level, primary, secondary, and tertiary level. So we developed a modular training model which actually kind of brings different modules together, so it can actually enhance interprofessional learning and also team-based learning, which actually has, I'll just show you how it works. So we actually have developed core modules which can be taught together with different groups of trainees, the ophthalmic assistant, technicians, and nurses. And then we have clinical practice modules and specific knowledge modules separately, so that they can kind of learn on their own, and we use blended learning as well. So this kind of helps us to optimize our learning resources, as well as they can have a team-based learning, team care, as well as team-based learning and interprofessional learning happens in this kind of training program. So the training provides a advanced certificate program, and we actually got the accreditation from JCAHPO in 2014, and this helps us to kind of standardize our educational program. With that, we kind of try to adopt the step ladder model of developing the career path for allied ophthalmic personnel, which is designed by JCAHPO, and we kind of developing a one-year program where we are going to combine the training for the ophthalmic technicians who use various investigations, and also we bring in ophthalmic imagers who use fundus photography, FFA, and other things, and also we have graders who actually kind of do the fundus assessment in terms of diagnosis and grading. So we also developed, we signed a MOU with JCAHPO to be a regional testing and examination center for Asia Pacific, which happened in 2017, and we are working towards developing our the technicians to be certified as certified ophthalmic technicians through an exam which happened in 2018 September. That's the first batch of technicians, and these technicians will be becoming regional trainers. So this is kind of a timeline to give you that we started in 2013 with a small program, then subsequently accredited by JCAHPO, and then we got the Regional Testing and Assessment Center and first batch of COT certification exam in 2018, and we are launching a specialist diploma for the ophthalmic investigations and hoping to have a regional training center by 2020 and professional conference for allied ophthalmic personnel in 2020. So our goal is to design ophthalmic workforce for the future using competency-based training program with a structured comprehensive training program and to be a regional training hub. Thank you. If you have any questions, I'm happy to answer.
Thank you very much, Bhaskar. We'll finish all the talks and then we'll come back to you.
Thank you.
Is the next speaker around? Yeah, please. Please sit down. We will do the thing.
Distinguished panel and my dear friends, thank you for having me here. Today we shall see how a working system in Brunei Darussalam can be used to enhance the already existing lovely system in India. I start with a tribute to my inspirational teacher, Dr. Babu Rajendran. Let's dream first before the dreams could come true. Brunei Darussalam is a small country in Southeast Asia, and it's situated in the island of Borneo. And it's just as small as slightly bigger than Goa and smaller than Sikkim. It's mostly a forest-led, uninhabitable area, and with Malay people as predominant, followed by Chinese, the language being Malay, the commonest language, and it's Islamic country with strong Sharia laws. If you observe the population density here, you'll see mostly they are of the working age group, in contrast to India, where it's mostly of the elderly age group. So that reflects in the GDP ratio which is being spent by the country compared to other Western world. The Western world spends more because they have more elderly population for the government to take care of. This is being governed by a very kind and compassionate king, the Sultan, who is very forward-thinking and also is ruling the country for almost 50 years now. He is ably governed, and he is governing a team of 14 ministers, and this is the Ministry of Health. The Ministry of Health, apart from other visions and strategies, has quality of life to be given to the people among the top 10 of the world. And the public there enjoy a variety of medical facilities. Mostly they are MOH based, and they are by the MOH clinics and the Ministry of Defense clinics, apart from semi-private and private institutions who cater to the needs of the people for which they have to pay. The advantage of the people is they have got a single electronic patient record system and a patient ID. Every citizen has an ID, which means if the patient is seen anywhere in the country, based on the electronic system, he can be traced, and all the past history can be taken. Even the pharmacist can give an issue, a medication given at the other corner of the country, and continuity can be maintained. The citizens form the majority of the public, apart from the temporary residents, and the citizens are given full access to medical care. Everything is subsidized. For example, if a citizen wants to have a cataract surgery with a multifocal IOL, with all the workup and the post-op with medications, they pay $1. And if it's a permanent resident, he pays $3 for the same. So this includes medications for glaucoma. Whatever medications is all covered by for the citizens there. The permanent residents pay slightly more, but definitely subsidized. But foreigners like us have to pay the normal charges, which will be equivalent to how we pay in India. Overseas treatment, which is not available in Brunei, is being sent abroad at the government cost, including daily allowance for the people, ticketing, accommodation, and full care. So with this system around, let's try to think together, and if we can pick up any points which we can use to influence the system which we already have in India. Of course, it's not common, it's not the same. Because if you see the banding, Brunei is banded among A in the WHO grading versus India is in D. Apart from these, Indian scenario is also slightly different because we are a democracy and we pay taxes, and it's a very vast country with patients having options to choose from. The implementation components are different. For example, if we decide to do a project in India, we have to choose a particular sample population. We have to choose who are eligible. Is it all people, or is it only the particular economic front? Do they participate in payment? Do they give a membership fee to understand the value of the care that we are going to give them? And do we give them all an ID number? We don't have an ID number common in India, but we have Aadhaar card and we have other things which are already prevalent. So if you can have an ID number, especially with having a barcode, then it becomes easier for us to trace the patients and uniform the information. Where are the access points? Are they going to community centers? Are we going to them with mobile screening camps, or do they have the base center to look forward to? And what facilities are we going to offer them, apart from vision, intraocular pressure, anterior segment? Are we going to do investigations there for them free of cost? Are we going to subsidize for them? Are we going to go for AI? As we saw in the inauguration, we're talking about artificial intelligence and telemedicine. Are we going to think of those for those target population? Well, these are some things we have to consider first. Medications, are we going to give them free of cost? Is it possible? Are we going to subsidize it them? Or are we going to give them any offers like glaucoma patients? You buy one, the second bottle is half free. This is an important aspect we have to look into, because India is a vast country with so many preventable diseases. So we do have to allocate a portion of our time and money into prevention. Of course, it's not without challenges. First is the challenge to identify which target and which village we're going to choose from. A lot of red tapeism, vested interests, which are going to block what we're trying to do. Of course, economics. If you're going to start a project, we cannot stop. So you have to think twice or thrice before we start a project. Are we going to give a global healthcare or global eye care, or are we just going to do screening once a year only? Of course, it's going to cause a stress to the provider if they're going to do it alone. So we need a community participation. So we have to choose a community which is willing to participate with our providing services so that they also share the load. To prevent stagnation, sometimes we see centers opening up at one place, stagnating there because they keep on providing, they cannot expand. So the logic would be to involve NGOs, the community, slowly start the project, share it with the community, make sure they're running it and supervise so that you can migrate to the next locus. And that's how you expand your services. And are we going to revise our eligibility criteria once we grant them is what we have to think again. Remember, there are medical legal implications which we have to take care of. What happens to a patient relocation? We choose a target and then the patient relocates to another state. Do we give them his medical records, copy of his investigations? How do we prevent misuse? In BRUNEI, these are not there because it's all centralized, and wherever the patient goes, the records are already there. In India, slightly different. How do they approach, even if they spend so little, how do they achieve it? It's because they engage the community. They engage the community to be a part, and the MOH objective is together towards a healthy nation. So they always say that we give you the services, but you have to take it and you have to run it actually. We have some well-established, very well-run systems here. For example, Arvind Eye Care system is being copied in many parts of the world. They've done it very well for cataract. For cataract, they've done it in a beautiful way, and it's running in such a smooth and economical, functional way. Can they expand it for other subspecialties as well? LVP-AI is focusing on quality. They've got the pyramid where they've got centers of vision centers and service centers which the patients can access to, and selected patients are taken up to the pyramid. Well, can we merge these systems? Can we incorporate further things? We have to dream. Remember, dreams transform into thoughts, and thoughts result in action. So let's have a wishful dream. Let's try to have a sample model scenario. Well, we have a provider community. We've already selected the area. We are not having to have one institution going to the area, but we're going to have a blend of institution plus NGOs. We have to involve the local ophthalmologists in the community, plus optometrists from the optical shops. What's the advantage? If the optician is coming from the optical shop, you don't have to pay him. And after he does the screening, he takes the patient back to his optical shop. It's okay for us, but as long as you don't have to pay him, and we're getting free services anyway. And patients get comprehensive under the roof. And these guys are not going to stop them coming to us. And plus the patients coming here will get an intraocular pressure checkup as well. So we identify the target population, we decide the eligibility criteria, we give an ID card which is barcoded, and then we empower the ID card. So what we can do, we can give three kinds of ID cards. ID card for the economically poor patients having full access to everything, the band 2 having an annual screening, or a band 3 having a subsidy where they have to pay a charge. Do they pay a membership charges? And do they have local vision centers for them to have a look, and what facilities are we going to give? So let's take a scenario here where we do have a patient who, say patient Satish, who gets a retinal screening intimation by SMS. And once he gets the intimation by SMS, he goes to the outpatient, shows his barcode, and then they get a vision IOP and refraction done, and a fundus check. the telemedicine component of the fundus camera, artificial intelligence, it just checks and says if the fundus is okay, the patient goes home, he comes for review after 1 year. But if it finds something abnormal, it alerts the doctor inside and the patient has to go and see the doctor inside. If the doctor inside finds something abnormal, he's going to refer for investigations. Otherwise, this patient goes home and he doesn't have to see a doctor. What happens when they have conjunctivitis or review for chronic uveitis? Then the doctor prescribes medications. So what does he do? He goes to the pharmacy approved by our team, and the pharmacist, and he flashes his barcode. The pharmacist, once he swipes the barcode, knows what medications the patient is having. Of course, for security purposes, the pharmacist will not be able to see the clinical records. He just sees only the barcode, he just sees the medications, dispenses it, and it goes on the system. So the patient comes back for review, we know the patient has taken the medications. And company partnership, what is the benefit of involving the pharma companies in this? The pharma companies, well, the name branding. So if they will get the penetration into the public, and if they give a discount on a particular medicine, say Lumigan, all the patients in that area are going to use Lumigan. So that brand is always there. So the advantage of them is the pharmacy companies get tax relief, they get the branding, and they have a social responsibility to do as well. So we should prevent misuse, and that's something which you have to look forward for. And for patients for glaucoma and other things, we can ask them to show the empty bottle. Their bottle will be marked by the pharmacy company that it's in this particular group, so they cannot misuse by showing somebody else's eye drop. The pharmacist takes back the eye drop and issues the next eye drop. And this eye drop goes back to the pharmacy company so that they don't misuse it again. So these kind of things will ensure the patient's coming for follow-up. And if they don't come for follow-up, we say, sorry, we don't get your medications again, you have to pay for it. Some incentives to make them come back to us again. For cataract, of course, the system is already in place. We do the workup, lasers, we do the workup, send them to the base unit. For workup, for cataracts we can offer, they're going to have free surgery with the minimum cost lenses. If they want premium lenses, they top up the cost. So we give them more charges, they pay some more, they can get better quality lenses. Otherwise, they still get cataract surgery, but they get the simple lens only. So post-op care will be given at the base center only. So this is something which came to my mind, which I thought we can probably incorporate on a trial basis. If it works, it works. Screening, of course, is important. We have the card. Every patient is reminded for an annual card. They come once a year for their screening program. And the system process should be like this. The main target, they identify the target area, they collaborate with local bodies, they set up the infrastructure, they run the services, they stabilize the services, delegate it to the local bodies and the ophthalmologists, and expand to the next locus. That's how it goes. At the same time, we should make sure we don't trample our competitors, trample the fledgling ophthalmologists in the group. We don't suck away their patients. We join them, encompass them as a family, and the whole thing should work as a family. Only then it works. With the government tax services, tax benefits, and combined effort, no dream is unachievable. It's only if you have to make an effort. Thank you.
Thank you very much, Azimuddin. We'll have the next talk by Dr. Peter Downs. I don't know why they have written Mr. Peter Downs. Are you from UK? Then UK you get called Mr. after you pass your FRCS. Yeah, I'm a Mr. in UK, but here I'm a doctor. Right, Peter Downs. He's going to talk about India's place in the world of ophthalmology. Since we are 200 years of modern ophthalmology in India. Actually, I have always had objection to 200 years because we have practiced ophthalmology in India since Shushruta days, not today. So that's a long, long, long time ago. But anyway, modern ophthalmology, they say, we have been practicing for 200 years. Never mind.
All right, well, thank you. And just, so happy 200th anniversary. That's 200 years of the outside world influencing eye care in India, but also the reverse, 200 years of India influencing eye care around the rest of the world. Right. So this is a little bit different from the other presentations you have here today. This is a little bit look at history, look at where we are now, and at what possibly could happen in the future. If you want more information on history, there are some wonderful eye museums in India, Elliott School's Eye Museum in Chennai, Museum of Ophthalmology, the Retina Foundation. So we know 200 years ago, Raja Sarfolji was integrating Western medicine with Indian medicine and providing eye care in southern India. And while he was influenced by the West, it goes the other way too. So a little bit later, Charlotte Ellaby, 1885 or 1884, came to Mumbai to set up the first eye clinic for women in Mumbai. And after coming here, she started studying Indian medicine. And we know that because she wrote about it later. And she saw that a lot of the teachings in Indian medicine were at the basis of teachings in Western medicine. And also that the medicines that Britain was flooding India with at the time, putting out of business local businesses, that the advantage was in manufacturing, it wasn't in medical knowledge, that these medicines from England used active ingredients from India. So a little later, Lieutenant Colonel Henry Smith and Noor Ali developed what became known as the Smith-Indian technique for cataract surgery. Became known around the world. Doctors from Europe and the US would come to India to learn the technique. These examples, snippets from articles before World War I in the US, all praising this technique as the safest yet devised for cataract surgery. Historians tend to credit the lieutenant colonel with developing it, but if you look at accounts from the time, people who studied with Smith really commented that Noor Ali was just as responsible for developing the successful techniques in the surgery. Moving forward, of course, independence was a watershed event because that brought national control over medical education and expansion of medical education and an upgrading of education. And it set the foundation for what was to come, the towering figures in Indian ophthalmology in the 70s and 80s who established many of the institutions that are now well known around the world. And set the role now for this is just a few examples, but many Indian ophthalmologists play key roles in developing technologies for international companies in ophthalmology today. Perhaps more important, or at least as important, is the fact that India is the global leader in cataract surgery. We estimate that 26% of all cataract surgeries are performed in India. Western Europe as a group is second, now at 17%, but that's 26 nations, not one. And the model that India has developed for cataract surgery, with a variety of methods of cataract surgery, is the most successful in the world, and it is really the only model for developing nations other than the established Western model. China, which very consciously established, kind of copied the model, but on faster track of Europe and the US. You see their cataract, these are numbers of cataract surgeries, are well below the numbers in India. And if you look at kind of the last 20 years, you're talking about tens and tens of millions of people more in India who benefited from cataract surgery than benefited in China. So in ophthalmology, India is the only successful alternative model of eye care to the established practice in US and Western Europe. China didn't develop one, Japan didn't develop one, and a lot of that relies on the importance of both Indian industry, making inexpensive IOLs, your use of your patent laws not being as restrictive as in the West, and in the use of MSICS development. I realize it was kind of first developed by an Israeli, but it has been perfected in many different ways here in India, such that it is spread around the world and even to the doorstep of the United States. Some of you probably heard a speaker here yesterday from Mexico about 6 years ago, the Instituto de Ophthalmología in central Mexico, in response to not always being able to provide phaco, sent people to Yerevan to learn MSICS, and they came back and set up their own training program in Mexico. And now graduates of that training program are setting up training programs in other countries, such as Guatemala, in Latin America. And this is, it's just examples, it's right on the doorstep of the US. They kind of always followed US practices and then realized that in order to serve their own population, they'd look for an alternative, and where they found it was India. If you look at technology being developed, you can also, many of you probably know about the MyLoop being developed by Iantech, which was acquired last year by Zeiss, so looking at MyLoop, and an aspirator system as a phaco-free cataract system, modern cataract system. And that is very much inspired by MSICS in India, and to the extent actually that the idea came from somebody watching YouTube videos of an Indian doctor making snares to slice the cataract. So even if you want to say, oh, might argue they're advancing it with advanced materials, whatever, it's still the inspiration of India is clear. India, however, has not been a leader in retina treatment. The slide on the left is for retina pharma. India accounts for about 1% of retina use in retina pharma. The slide on the right is retinal surgeries. India, despite its large population, is about 8% of vitrectomies worldwide. Nor has India been a leader in glaucoma. Slide on the left is glaucoma surgeries. India accounts for about 4% of those worldwide. Slide on the right are units of glaucoma medicine sold. India is about 12%. Now, and this time you don't have to make an adjustment for revenue because those are units sold. So it's 12% despite the population being much larger. But I think we're at a point in history where there really is a potential for India to become a leader in these areas as well, and thus really set the path for world ophthalmology as a whole. And if you look at, again, retinal disease, some of the things being developed in India and technologies probably likely to be adopted here before adopted in Western Europe or the US. For example, smartphone-based fundus cameras. Doctors Venkatesh and Singh Gupta, I'm sorry I mispronounced the name, their site Aravind said Remedios provides equal performance to a desk-based camera at 1/5 the cost. Jay Chablani at LV Prasad Institute has been a leader in investigating the use of zivaflibercept as a very inexpensive alternative to Eylea in wet AMD, and he's been doing it for a few years. November was the first paper at the AAO by Americans on this topic. And India, of course, has been a pioneer in developing biosimilars. Maybe I can have 60 seconds more. In glaucoma, inexpensive perimeters being developed. Elisard, based in Chennai, sprung off from the Argowal Eye Hospitals, has won for about 1/3 the cost of a desktop. Another company, I think Oralab, has been negotiating for the Toronto portable perimeter. And their goal, it may have changed, but their goal early in the year was for a perimeter that costs about, a portable perimeter that costs about $30. So I guess that would be about, what, 2,100 rupees? An Israeli firm, Sanoculus, negotiating with Ophthalmology to do a stentless MIGS for $100. And of course, primary SLT is you have an option here. Americans have not looked at that, Western Europe, but new studies coming out. There's a 3-year study from Moorfields, going to be published in Lancet. So primary SLT is as effective and safe after 3 years as medication. But in England, of course, it's much cheaper. I'm not sure what the situation would be here in India. Again, I don't know if any of these individual technologies will be successful. That's what you will decide. Find what works clinically in your practices. But I think the point is that a lot of the world, developers, new startup companies and developers are looking really at India as the land of opportunity for developing new technologies that will really disrupt the ophthalmic industry and replace technologies being used today. Thank you.
Thank you very much, Dr. Pikidan. Let's have Dr. Arthur Klett here for the next speaker. Please come. And we'll have discussions after the last talk. Then we'll go one by one. I think the first discussion will be about neurodevelopment after ROP treatment with VEGF. After all the talks are finished, if you kindly come in the front, we can have discussions on that. And Dr. Arthur is going to talk about burns, reconstruction after periocular burns. Yeah?
Good afternoon, everybody. Once again, thanks a lot for inviting me to this wonderful meeting. And in my talk today, I would like to share with you my experience with reconstructions in the burn injuries. The eyelid involvement is quite common in facial burns, and the goal in the management of every case is first preservation of the vision, secondly prevention of the future complications, and finally restoration of the cosmetical acceptable appearance. Important point is that using flaps in this region is quite limited. Shortly about the general technique, we started with preparation of the contracted skin, and then measurement and preparation of the transplant, and finally transplantation of this graft piece to the covering of the defect. From where to take the skin? Option number one would be always upper lid of the contralateral side. If it's possible, of course, usually it's not. Option number two, retro or pre-auricular area, then supraclavicular area, and in case when we need a large transplant, we can take it from the inner side of the arm. This first example of superficial thermal injury and contraction of the surrounding skin leads to lack of thalamus and ectropion, which in this case was corrected using classical Tenzel's semicircular rotation flap. And intraoperatively we have to look to create a nice lower lid contour of the lower lid eyelid margin. This is the more severe case after electrical burn, and is the patient 2 months after skin transplantation done in general hospital to covering the defect on the lateral side of the head. And now he had a dramatic cicatrical ectropion in leg of thalamus. And in this case, it was corrected using full thickness free flap grafts from the contralateral upper lid combined with retroauricular skin graft. Crucial is in the end of the surgery to put a tractional suture for at least 2 or 3 days. Here's the patient pre and post, and because the most common side effects or complications in electrical burns is cataract. Here's the patient next day after cataract surgery in the one side, and to wait now for the cataract surgery on the right side. This case is very interesting because of very long history. He came to our clinic actually for cataract surgery, but the history is 22 years after explosion in the military. And look at closer and you can see that this is total eversion of the upper lid and lower lid, the no skin on the upper lid, and the total keratinization of the eyelid conjunctiva. And in this case, we started the management first with excision of the keratinized conjunctiva and replace it with amniotic membrane, and eyelid defect was corrected using 2 flaps technique, one part for the palpebral part of the this area and the second part for the orbital. And is the patient 2 weeks postoperatively. The pupil is dilated because the patient comes finally for the cataract surgery on the right side. This is the very dramatic bilateral eyelid defect after gas explosion, which was corrected using many flaps in 2 or 3 steps. This is a very severe case of lower lid ectropion and lag of thalamus unilaterally, and in a case like this, the presence or absence of the bell phenomenon is very important for cornea protection. That for this must be or should be always documented in every case. In this case, we used again many steps for combined free skin graft rotation flaps treatment, and is the patient 6 months postoperatively. Aesthetically, it is now quite fine, but look at what happened with your hands. That is a big challenge now for the orthopedic surgeons. This patient with severe cicatric ectropion involving the upper and lower lid, and in both sides with an inability to close the eyes properly. And also the bell phenomenon in this case is very important. And to reconstruct all this area, we used about 4 to 5 steps, step by step, to put a piece of skin graft to reconstruct all this area which was damaged during this injury. And is the patient 6 months after injury, the visual acuity of the both sides is 0.6 to 0.8 because it's slightly cloudy cornea. And again, a big challenge for orthopedic surgeons. This case is very important to show what happened with the cornea very quickly if after this damage the patient is not able to close the eye. And this cornea erosion would be in few days, ulcerate and probably perforate. That's why a situation like this is very dangerous and need for the urgent management. Here's the patient after eyelid reconstruction, and once again, like in the previous case, as a side effect after electrical burn, he had bilateral cataract, which was now successfully operated. Summarized, the severity of burns depend on the intensity, on the burning agent, also of the duration of the exposure, or some of the first aid, or some protective devices or protective actions. Superficial eyelid burns usually heal spontaneously. It can be managed conservatively with ophthalmic ointments. And thank God, the permanent visual impairment is rare if the prompt management is done properly. Thank you for your kind attention.
Thank you very much, sir. Thank you very much for that lovely information. We'll have a discussion in a few minutes. Kindly sit in the front so that all the speakers, if they can sit in the front, it's easier for the discussion. Now we have Dr. Sharafuddin Ahmed from Bangladesh, who's going to talk about community approach for prevention of blindness in Bangladesh, which can be applied, if possible, all over the world. Am I right? That's what he's going to talk about. Please start, sir. The time allotted is 8 minutes, and you will get a message all the round.
Good evening. I am from Bangladesh. Thanks for giving me chance in AIOC for my presentation. My presentation is on prevention of blindness community approach. You see, you have to go to that guy. You have to go to that. Oh, I have to go there. Now, you see there are many sorts of activities in the world for the prevention of blindness, and we are not the lacking behind. In our country, something new is that for 6,000 population, we have a community clinic, and these people are not the doctors. They are becoming the trained personalities, and they refer the patients, and from this community clinic, the patients are being sent to Upojela and then district and then tertiary levels. The causes of blindness in all the countries are like that. In our country, accidents are the much more, and cataract, glaucoma, diabetes, degeneration of the ocular tissues, and in Bangladesh, uncorrected refractive error are much more, about 40%. Global blindness scenario, you know, every 5 seconds one individual in the world goes blind. Globally, there are nearly 45 million blind people and almost 135 million with low vision. 9 of the 10 who are blind live in developing countries. 3/4 of the world's blindness is avoidable. The percentage I already told, that cataract 65% and refractive error 19.7%, and glaucoma is 1.8%. Due to what are the epidemiological factors? These are the age, sex, malnutrition, occupation, social class, and social factors. The people also move still to the older drugs, still the water from the snake, or they are using the gulab jal water, and they are going to quack. The prevention of blindness, initial assessment, methods of intervention, long-term measures, and a specific program. Our national program in Bangladesh is probably responsible for over 60% of blindness between 1994 and the end of 1999. In our country, there is the modular eye care project, provided a range of diagnostic, clinical and surgical services being equipped to perform high volume ECC, SICS, IOL cataract surgery, each base in the base hospital, some of which are provided non-ocular medical services, had a network of 4 primary eye care courses, centers. General doctors trained in primary eye care and refraction worked in the primary eye care center with nurse and organizers. They treated simple eye conditions, counseled patients, referred those needing treatment for more complex condition, and followed up patients discharged from the base hospital. The organizers worked the local community group with ophthalmologists from the base hospital. And in our country, there are the mega eye camps project where about 500 to 600 operations are being done by 2 to 3 days. They identified patients needing surgery at the screening camps, and also there are the district focus and comprehensive eye services. The major features of the modular eye care models were as follows: modular approach and sustainability. This modular eye care is the objectives of to reduce the backlog of blindness, about 8 lakh in our country, and every year about 80,000 new population are becoming blind from cataract, to develop eye care facility for every district, also eye care facilities for the development of the human resource, and to secure participation of the civil society and private sectors. The 4 strategies are there: strengthening service delivery, developing human resource for eye care, promoting outreach activities and public awareness, and developing institutional capacity. National level, secondary and primary level, with the government, this type of activities are going on. There are some NGOs and the trainers, and also collection of the donated eyes are also in our country for the prevention of blindness. Still, due to religious factors, the eye collection and donation facilities are being less in our countries. District Blindness Control Society, we have major objectives to achieve the maximum reduction in avoidable blindness in the district through optimal utilization of available resources in the district. This society acts to implement, monitor and keep the financial account of the program under chairmanship of the district magistrate and collector. We have the Vision 2020 program like all the countries, and in our country, lastly, there was the program Right to Sight. Is an international campaign to create awareness and mobilize additional resources for preventing and treating blindness. It is the partnership between the countries, the World Health Organization and non-governmental organizations to reduce the avoidable blindness. And we had the 20-year program for 4 phases of given each year. And there are 3 essential elements: disease control, human resource development, and infrastructure development for the Vision 2020. And we have community vision centers. This vision center will help by providing permanent eye care facilities in rural areas, motivate people to seek earlier treatment for vision problems, allowing them to reintegrate back into the workforce instead of becoming visually impaired. These centers are equipped with basic ophthalmic equipment like slit lamp, autorefractometer, strict retinoscope, direct ophthalmoscope, trial set, shiostonometer, basic sterilizer, BPF instruments and computer with a digital camera. These centers are run by well-trained 2 ophthalmic nurses who perform slit lamp examination, refraction, treating minor ailments like foreign body removal, counseling, etc. And all vision centers are linked up with the Sheikh Faziluddin Nesa Mujib Eye Hospital and Training Institute, which institute is also renamed by the name of the wife of our father of the nation, Bangabandhu Sheikh Mujibur Rahman, which is situated in the district, Gopalganj district, for consultation and also to access secondary and tertiary level eye care. All patients are examined in the vision center and they are sent to the ophthalmologist of Sheikh Bangabandhu wife, Sheikh Faziluddinesa Mujib Eye Hospital and Training Institute, who will interact with the patients as well as patients who require procedural intervention. In addition to the vision center, one ophthalmic nurse acts as a coordinator to look after non-clinical activities such as registration, maintenance of records, statistics, interaction, etc. In addition to the vision center, they maintain the registration, and with this, the people who lives in the rural areas, they are being referred to the tertiary center, and I think this vision, community vision center will help in the prevention of blindness in our country, and this can be utilized in other countries. And community clinic, the rural, only 6,000 population, they are living in the rural areas, they can be treated, and in this way prevention of blindness program can be continued. With these few words, thank you very much for patient sharing.
Thank you very much, sir. Please come and sit down. We'll start some interactions. We have heard you, and we also have some doubts to clear, so that we all understand each other better. Because English is a funny language. The words do not necessarily mean what they are meant to mean. They mean more or less, or they mean nothing. So let's start with Dr. Michael Blair. Sir, if you come here, or if you want, you can use the other mic for answering. If you come here, everyone can see you. And now, I am a pediatric ophthalmologist. Actually, I was trained in England, where we do everything, from oculoplasty to retina to squint to cataract. Everything we used to do long time ago, and then gradually we realized that it's not possible to do everything, and we restrict ourselves to some aspects. Now, I also see many patients, children with ROP who have received Avastin, who have received laser, etc., etc. The primary doubt I have in my mind is, they say you have to use 0.47 milligrams of Avastin, or half the amount they said what you give normally. The question I asked was, the eye at birth is 80% of the adult eye. Why did you suggest 0.47, which is slightly less than half the amount that you use in adults? Nobody has given me an answer correctly.
We don't know the best dose.
Okay, that is the correct answer.
Somebody just said, let's give a smaller amount, and they picked half. And, so there is a ongoing dose de-escalation study in the U.S. where they're trying lower and lower amounts, and they found, with 1 month outcomes, at 1 month, most of the eyes do well with 10 times less or even 100 times less the dose. So what is the optimal dose, and what's the best dose for 3 months later or 6 months later? Do you need to use a small dose and re-inject several times? Or we don't know the best. And it may be that different babies' eyes, as they grow and need treatment at different ages, are different sizes, and the amount of VEGF produced by the retina may be different. So it's going to be impossible to individualize. So you're just going to have to stick with sort of a standard dose, and this is what we have right now, but it may not be the best dose.
And you're going to inject this in both the eyes. Usually ROP is a bilateral disease, probably with varying degrees of affection of each eye. But it's going to be, if one eye is going to need Avastin, it's most probably the other eye also needs Avastin.
I basically treat both eyes at the same time, whether it's Avastin or laser, whatever it is.
Yeah. Now, one of the important doubts in my mind is VEGF is needed for normal neuronal development both in the retina and in the brain. How are we going to ensure that it's not going to leak out into the brain and cause damage? We don't know.
We know that some of it gets out of the eyes, some of it gets into the bloodstream, some of it gets into the brain. What we don't know is what is the effect of that. And we've been doing AVAST in my center for 10 years or more. And here in India, they've been doing it for over 10 years, Mexico, a lot of Chile, a lot of countries, they've been doing it for over a decade. And there have been no reports of severe neurologic detriment from it. So you might argue, well, there might be a small detriment that we're not picking up, and yes, that could be true, but it's not causing gross defects in neurodevelopment. Otherwise, we would have had reports.
We would have had reports. Do you think this is a one-off treatment, or are you going to repeat it, observing the child, give one injection, observe the child, and maybe need 2 or 3 injections?
My opinion is that the injection is a great first treatment, but I don't think it's the only treatment. Some patients may have a reactivation acutely in a few months, at which point you can do laser or you can do another anti-VEGF. But I actually think that there's a decent number of eyes that later, and we've reported at age 2 and age 3, where we've seen bilateral traction detachments in kids who had avast and no subsequent treatment. So my strategy is around 60 weeks to laser all the avascular retina at that point. So I think they all need retreatment. Some people argue that maybe retreating too many, but I prefer to do it that way than to have surprises.
Would you think or would you foresee this replacing laser as a form of treatment for ROP, or not really?
I think
down the line.
I think it will. I mean, in AMD, anti-VEGF has replaced laser. In diabetic retinopathy, it's replacing. It has basically replaced focal for diabetic edema, and it's replacing. And there's still arguments about for proliferative disease and issues with loss of follow-up. But I think that it's going to replace laser as initial treatment. I still have worry about things in the future, and so I think that combination may be the best.
Because in India, we have recently, when I was the president of AIOS, there was discussion, and we started a society for the ROP. We are sitting on a time bomb in India. Every day, 50,000 children are born, and about 5 to 10% are premature births. 5 to 10%. That's a phenomenal number, and the amount of, and there is no way to screen these children. Although we have developed our own system of screening with equivalent of RETCAM. We have identified and we have managed to do that in one southern state, Karnataka, where they go into the periphery and take these premature children and take the photograph with RETCAM and send it to the Central Institute in Bangalore, where they analyze this retina and bring the child back who needs treatment. But that is only an isolated incident. If you look at the problem, seriousness of the problem in India, they are not dealing with it. The government is not doing anything.
Well, what you could do is, if you had RECAMs or similar devices, that you could teach nurses to take pictures at most hospitals. Is not challenging to take a picture of the posterior. The periphery is hard, but you can get a picture of the posterior pole and you can look for plus disease. And plus is the major indication for treatment. So you can screen without physicians. You can have other people take the pictures, and those could be read. And where I think that anti-VEGF, one of its main benefits is the ease of administration. Laser is technically challenging. There are people who are very good at laser, but that takes a lot of training. Whereas you can take a nurse or other practitioner and teach them to do injections. And so you might be able to treat a lot of these babies without having physicians present all the time. If you have screening remotely, someone has to make the decision, or it's Google or some artificial intelligence thing says, yes, treat. And then a local practitioner who may not be a physician, but if they've been taught to do an injection, could potentially treat. So that's a way that you can expand the babies that are treated without all of a sudden having a lot more physicians.
So from our point of view, I feel that if anti-VEGF is a better alternative to laser when the number is large, huge. Because we can treat a local ophthalmologist, we can teach a local general ophthalmologist how to inject intravitreal rather than how to do laser in a very small infant, which it may not be possible.
Right. Laser in infants is technically challenging. I mean, you know, you can get good at it, but an injection in a baby, pretty quickly you can do it safely.
So probably that may be the way to go forwards in India for our problems.
No, sir, but training a general ophthalmologist for intravitreal injection will create medical legal problems.
No, no, nothing like that. That issue has been sorted out. There is no medical. It should be possible for us to teach a general ophthalmologist how to give intravitreal injection in no time. But it is not possible for us to teach how to do laser in an infant. It's not possible, particularly in a premature. You have to do laser in a premature infant. You are not going to wait for 6 weeks or 10 weeks and say do the laser. It's not going to work like that. So it's easier to treat within 2 or 3 days. We can teach how to give intravitreal, but we can never teach how to do laser in 2 or 3 days. Am I correct in that?
It takes months to learn how to do good laser. And in injection, I mean, if you have somebody who's capable, I could teach somebody in half an hour to do a safe injection. There's just a few little tricks you have to do to avoid the lens and retina.
Yes. Can you give a frame of?
I think it's the need which determines what can we do with available resources. In Singapore, we actually train our nurses, who are trained ophthalmic nurses, to provide injections for adult patients. I mean, we had discussion. I was discussing with Michael earlier, so he was asking me, "Are you giving for children as well?" So we have not started, but at least for the adults we have started. So we have a structured training program where the nurses are trained and they are supervised by ophthalmologists for certain X number of injections over a period of time to meet a specific competency. So similarly, if by different states, the ophthalmology societies can actually identify a specific center where that center can be the IVT injection training center, where the general ophthalmologist can go there and train, or even GPs. I'm not sure. Whatever.
My concern is that India is a country where even ultrasound, for doing ultrasound, an MBBS can't do only.
Absolutely. You have to have the
gynae people and specialists are advised. They can do this thing, radio sonography.
But this is an intervention.
Yeah.
Ultrasound is an investigation. So you require proper training, because that investigation leads to a diagnosis.
That is what I'm saying.
So that's what I'm saying. The differentiation is the investigation leads to a diagnosis, which is going to be an intervention support. But here it is an intervention where you can train the person who is a competent ophthalmologist. General ophthalmologist can actually be trained to provide injection. That is an easy alternative, I would think.
It can't be an outdoor procedure.
No, it has to be under sterile condition.
So
it has to be under sterile
every
condition, but
GP
I'm saying that you have significant resources. You should identify a specific center within a state or even district. Major districts can be identified as a specific IVT training center and can be a referral center for IVTs and things like that. So that can be a way we can actually explore.
But I doubt, because everything is ruled by judiciary. And
then you should make a plea to the judiciary looking at the
It is possible. We can't change.
Yeah.
Actually, we have done that for B-scan.
Yeah.
Now, my question is, supposing you give anti-VEGF, Avastin only comes to my mind. The amount of the laser you do, can it be reduced, or the other round? If you have done laser, the amount of VEGF need will be less, or there is no correlation between the
So
two?
if you do it sort of staged, which is how I do it, I do the anti-VEGF, and then as that drug wanes, the vessels start to grow intraretinal anterior. At some point they arrest again, and then so the amount of laser that you do is much less. It's a much smaller swath of retina. And actually we found even when we do the anti-VEGF with late laser, their refractions are close to plano, versus if you did initial laser, they're -6 or -7 or something like that refraction. So it's much less laser that you have to do. Conversely, if you do laser and then anti-VEGF, now you've disturbed the blood-retinal barrier and more VEGF gets out of the system. So it's better to do anti-VEGF and then laser, so you can have less systemic effects, and then less laser also, so less ocular destruction. Their visual fields should be better. We haven't measured that. We don't have enough kids who are old enough to do visual fields accurately yet, but they should have much better fields.
Okay. Anyone else has any questions to? No? Thank you very much,
you.
sir. Thanks a lot. Now we have the next speaker was Jai Bhaskar. Do you have any questions?
Yeah.
Yes, sir.
See, most of the teaching or paraclinical teaching are associated with the clinical institutes in
Yes.
India. And these days NABH or pre-accreditation is there in the vogue. So where does the JCAHPO stands? Is it a separate certification or there is some kind of the correlation with NABH or pre-accreditation?
No, it's actually an international accreditation process
Yeah.
where the JCAHPO accredits a training program and the institution. The purpose of the accreditation is to ensure that the training program meets certain standards. And it actually has specific competencies to be achieved. So when you have a curriculum to train this paraclinical, as you say, the AOP's training program should have certain objectives, learning objectives, and the curricula has to spell out. As I showed you the curricula overview, that has to be conformed to what the standardized guidelines given by JCAHPO. And I know different institution has different curricula to teach based on their needs. In some institutions, you have optometrists to do most of the investigation. Some institutions don't have optometrists at all. Some institutions do get the nurses to do the investigation. So the practice varies. But if you want to standardize, that's the thing I was trying to say. So if you want to have a productive allied ophthalmic personnel with specific competencies identified to their portfolio and identify them as a specific profession, like what we do is actually ophthalmic assistant is actually similar to a clinical assistant supporting the nurses in the clinic. So the vision technician, as you say here, and the ophthalmic technician that we have, they have much broader scope of practice. So these are the curricular components that we actually kind of evaluated by JCAHPO, and they have a standardized curriculum. So that they will evaluate and they say that yes, your training program meets this international standards. This is actually developed by a panel of international experts, which is in participation with the ICO, and JCAHPO actually set this standardized guidelines. So our program actually conforms to that, and that's where the accreditation comes in. So it is actually a 3-year process. So every 3 years they will come and assess in terms of whether we are doing well, whether there are any improvement needed, and they will interview the candidates in terms of the learning expectations are met, whether do we have the institutionally, do you have the training resources to achieve what is the learning outcome that is you are proposing in your curriculum. So all these things is done by an independent entity. I think the accreditation part is quite new to India, I assume, because
No, it's not new.
no,
Earlier,
I'm talking about the educational program accreditation. The
Yeah.
institutional accreditation for NABH is actually for safety, quality, and other stuff. This is training program accreditation. So that's a different thing altogether. So in other parts of the world, they actually have, if it is a university or any of the training program offered, that is actually to be reviewed periodically, and they have to conform to specific outcomes, I mean specific standards and outcomes. So that is actually to maintain the standards and quality of the program. That is the value of external body coming in to assess your training program, to say that yes, you have the required training resources, the trainers are competent, and the training outcomes are suitable for the standards that they are looking at, and things like that.
my consideration was only that since most of these paraclinical institutes are associated with the hospital or clinical institute, and when there are already NABH or some kind of accreditation there, so is there any kind of the preference or some kind of the points taken into your JCAHPO, or is separately, totally separate?
It is one of the other components that they will look at. So whether the institution has a certain clinical safety standards, so that will be
That may be.
taken into consideration.
Yeah.
So NABH can be one of the plus points if the institution already has. And I don't think all the clinical institutions have their own training program. Probably they will hire from other institution and they will get the person work
Yeah.
in their own environment.
Yeah.
But these kind of training programs will be helpful when it is assessed by external party. The feedback is more useful. What we learned from their feedback is that reflection practice is a key because it helps the trainee to kind of reflect upon a case when they are facing any issue, whether it is patient is not happy with the way they are treated, or the colleagues are not doing support, or teamwork is not working, then the reflection actually comes into the training provider or the program director. Then they will be going down to the training area and try to mitigate those issues. So it's a constant feedback mechanism helps. That's what we understood and we implemented in our training program.
Okay. Thank you very much, sir.
Yeah.
Anyone has any questions? Okay. Thank you.
One thanks for Mr. Peter Down. He has
We are coming still. Dr. Azimuddin. We're going in the order.
okay.
Now,
Yes, Dr. Santa.
I have one question. I was very impressed with $1 cataract. What is the percentage of allocation of health
2.5%.
GDP?
2.5% of GDP, sir.
2.5% of GDP. Because in England, they have patients don't have to pay anything for their cataract, but they have a waiting list of 1.5 to 4 years.
They pay tax. England, they pay tax. Here, there is no tax. This is a tax-free country.
Let me complete. What I'm trying to tell you is when I was working there, we didn't have the connection between the hospital records and the death records. So we send a letter, dear Mrs. So-and-so, would you be happy to come in for cataract? And then they come and say that she died 4 years ago. Because we had no idea that lady on the computer of our hospital has died 4 years ago because the two were not talking to each other. So when you give anything free, there is going to be and bound to be a long waiting list, people who don't want to spend money on their health. So how do you give this $1 cataract? We do cataract free in India, thousands and thousands. Cataract is no longer the important preventable cause of blindness in India. The preventable cause of blindness in India has become ROP, not cataract. So how do you give $1 cataract? Let us know your views.
This is a monarchy. So, so the money is with His Majesty. So he decides how he likes to distribute the money. And the population it's an oil-based economy. And they have only 450,000 people. And so considering the revenue versus the number of people, the ratio, that's why it's considered one of the richest countries.
Okay.
So that economy, His Majesty being kind enough, he's focusing on healthcare. And the healthcare is completely free for the people. They don't pay tax. And in fact, I couldn't elaborate much because of lack of time.
No
They even get a pension. After when they reach 60 years, they get $350 pension. Everyone, irrespective whether you're rich or poor, they all get it. But you have to be a citizen there.
Now, what about the waiting list?
The waiting list is between 4 to 6 months.
4 to 6 months.
That's manageable.
Because there'll be some patients with 612, 69, they still would like to have surgery, so they get into the queue. Otherwise, the waiting list can be made shorter.
Okay, anyone else has any question? Thank you very much, sir.
Thank you, sir.
Thank you. Mr. Peter Downs. His Dr. Peter Downs, I love that Mr. Peter Downs. Now, I learned my cataract from modified Smith-Indian technique days. I don't look old, not the original Smith-Indian and modified Smith-Indian. We had modified this Smith-Indian technique in India around the 80s.
Okay.
And that's when I was trained to do the cataract, modified Smith-Indian technique. To femtoflax. I have seen the whole array of cataract operations. Now, India has been a world leader in cataract for a long time.
Yes.
And I am glad you people are appreciating and understanding the quality service we are giving. But one of the problems I notice is that the industry is driving what we are doing in India. Everybody is talking phaco, and nobody is talking about the small incision cataract surgery, which is popularized by India all over the world. Leave out the West, because in the West the industry is taking care of your cataract. There was an article in BJO about the value for money. of small incision cataract versus phaco, and they realize it's tremendous advantage. So in the West also you can adopt this technique. There's nothing wrong with this technique.
Right.
So what's your opinion on that?
Well, I've noticed in the last 2 years at AIOS, there's more attention in sessions devoted to SICS than I think there had been previously. And I want to give AOS a lot of credit in publishing the proceedings from the session, The Magic of SICS last year, including videos. That's a tool that I think will open a lot of eyes. I showed that to somebody who's been involved in ophthalmology for about 30 years in the U.S. In the U.S., most doctors, and I think this is true of Western Europe too, think, if you mention SICS, they think, oh, that's just ECE. Okay, and it's not. But that's what they think. They say that's CCE. And in fact, last September at ESCRS, Orbis sponsored a session, SICS versus phaco, and the speakers were, you all need to talk to them and actually get an Indian speaker there, because the speakers they had were someone from the UK and someone from the US, and they both agreed that SICS was just ECCE. So talk to Orbis. Next time they do a session like that, have a speaker who knows what SICS really is. But anyways, I showed the video to someone in the U.S., and he was floored, because he had thought SICS was just ECCE, and it could only be used on a rock-hard cataract. And he looked at these videos, and he said, I had no idea you could do that with SICS. He said, and if you can do all that with SICS, why are we bothering with phaco?
Precisely. Precisely the point.
I just want to confirm that I'm from Singapore, so Singapore National Eye Center. So we are exploring using SICS in our training and practice as well. So we started this some time ago, but then it died off. But now we are putting a lot of effort. So some of our team actually went to a couple of institutions here. There is SICS training program is given. So we already have a couple of senior consultants trained in SICS, which we are going to incorporate into our residency program. So it is in place. So we do.
Ahmed from Bangladesh, please come, sir. Do you have any questions? 2 minutes. We have only 2 minutes. We are totally ignorant about your. Now, I don't do oculoplasty, so I can't ask you anything. You have
Yes,
any
sir.
questions?
As you have said that some community clinic there is going on. In India also there is concept, especially in Delhi, that is the name of the Mohalla clinics. But that is for the general health checkup. But this is point well taken that such specialty community ophthalmic clinics can also be started in our state or in all over the India. That is a nice way to bring down the avoidable blindness count down.
In our country, it is about 13,000 community clinic nowadays, and in future it will be about 40,000. That's because for each 6,000 population, there is one community clinic. The people who are not ophthalmologists or ophthalmic trainee people, but we are thinking that the community healthcare provider who are working there, they will be taken up and they will be at least trained that the where to go the patients to whom, whether it is in the primary level or in the secondary level. And I think if it would be possible in future, we are thinking that the Upazila medical officer, it is in the Thana, he will go at least once in a month to these clinics, at least to counsel the patients that they should go where, when, and how this ophthalmic treatment can be done for prevention of blindness. Thank you.
Thank you.
Thank you, sir.
Please come to the dais for a group photograph.
Yeah, Dr. Arthur, sorry, I have to wear my glasses. If you had talked about presbyopia, I would ask you, Arthur Clegg. Now, I have absolutely no idea what you are doing, but you are doing a wonderful job. That much I can tell you. I cannot ask you because I don't understand a word of what you have said. Sorry about that, but we don't have oculoplasty surgeon here.